out of the ordinary insights. Brought to you by Investec Specialist Bank.
Welcome to this Medical Captains of Industry event coming to you from the Investec headquarters in Sandton, Johannesburg. We're joined this evening by an esteemed panel, and to my immediate right I have Professor Ian Sanne, Professor of Medicine at Wits and CEO of Right to Care. Dr. Carol Ann Benn, who is a specialist surgeon and breast care expert. We are then joined by the Deputy Minister of Health, Dr. Gwen Ramokgopa. To her immediate right, we have Dr. Ridwan Mia, plastic and reconstructive surgeon, and then Dr. Jonathan Broomberg, who is the CEO of Discovery Health. Thank you all very much for your time this evening. I'm now going to ask you to introduce yourself and really to take a minute, 2 minutes to introduce yourself, highlights of your career to our audience this evening. And I'm also going to drop the formalities. So it will no longer be Doctor, Deputy Minister. I will continue to observe protocol because I want to get an interview the next time I ask you to grant me one. Ian, can I ask you to introduce yourself to the audience this evening?
So thank you very much, Bronwyn. Also thank you to CNBC and Investec for the invitation. I'm an infectious diseases specialist. I qualified in 1996. Quickly after that, became involved in HIV, predominantly HIV research. I've built up the clinical HIV research unit at Wits University, predominantly NIH funded, National Institute of Health in the United States, some European Union funding. In 2001, I decided to try and expand access to antiretroviral therapy in the country and started a non-profit organization called Right to Care, which today is very active in the treatment of HIV, tuberculosis, cervical cancer, children, predominantly funded by USAID and under the President's Emergency Plan for AIDS Relief, and we're a prime recipient of Global Fund. And very interesting development in 2003 was the start of a health economics and epidemiology research office called HERO at Wits University, a collaboration with Boston University. And I think that indeed has done the most formative, most influential research work with its impact on the national costing model for antiretroviral therapy and the national costing model for TB diagnosis.
Thank you very much. Carol.
Hi, I'm Carol Benn. I think being a woman, I won't tell you when I graduated, but there we go. Suffice to say, I've got about 20 years of experience in managing women's health and breast health. I'm a specialist surgeon, and my interest is breasts and breast health. I've set up clinics at first Joburg Gen and then Pisani Barrow, where we had 2 patients in a cubicle next to the urology cubicle, penises in one and breasts in the other. Increased that in size to about 200 women, and then was moved by the health department to a big unit at Helen Joseph, where we have a massive unit. We have 2 open access clinics a week. We have 4 lists a week. We see many patients. I set up a Netcare Breast Care Centre of Excellence because you have to have private and public partnerships, because through that media we can reach women throughout the country, and no one ever drowned in sweat. It's about hard work.
Deputy Minister.
Hi, good evening. I'm Gwen Ramokgopa. I've also done a master's in public health. I've been largely in the public sector, but I've also done my stint in the Independent Development Trust during the transition into democracy as a funding agency for health sector developments and clinics and all that. And I was an MEC for health in Gauteng. I also did my stint as a mayor of the city of Tshwane, and I prioritized also public health related issues there, over and above making sure that I leave the city financially viable. I think Investec can check that out. And now I've been asked to be the Deputy Minister of Health.
And you've got the challenge of changing the face of health in South Africa. We'll be drilling down into that further in our discussion. Ridwan.
Hi, Ridwan Mia. I'm a plastic and reconstructive surgeon based at the University of the Witwatersrand, like most of the panel here. Also do practice in private as well. My interest specifically in plastic surgery, post-cancer reconstruction, hand surgery, burn surgery, and many of you know about my interest in tissue engineering field, which includes cloning of skin. And we had the famous case of little Puppy Kruger a year and a half ago. So we're aimed at furthering the pioneering field of tissue engineering under the guise of plastic surgery in South Africa, which is really a world first, I think. And I think generally I look at just improving education. I'm very keen on education both at a basic and tertiary level. I'm part of a project called Project Distinction, where we incentivize children in the township schools to improve their matric results, to stay in school, not only just to get them there, but also to give them hope. I think there's a big lack of hope amongst our children, and so that's something I'm quite passionate about.
Johnny?
Thanks, Bronwyn. Good evening, everyone. I started my career as a doctor too. I think we're all doctors here on the stage except you.
Oh, thanks for pointing that out. I really feel now out of my league.
But shortly after graduating, I moved into the field of economics, and I eventually did a doctorate in economics in the UK. And I've spent most of my career really at the sort of meeting point of economics, finance, and healthcare, doing many different things. I worked in the public sector for a long time in academic research. I've done various things in the private sector, and I've been with Discovery Health for going on 10 years now. And I've been the CEO of Discovery Health for 4 years. So that's me.
So now let's look at the state of healthcare in South Africa. And from the outset, I'd like to state that we're going to create a solution-based debate where we look not only at the problems, we touch on them, and then we move to the solutions. And where we can, work together as government and private sector to alleviate the stress that we're seeing in some sectors or some environments within the healthcare environment. So Ian, let me come back to you. Let's talk about how you perceive the state of healthcare in South Africa at the moment.
So I think that the public, one has to divide it into private sector and public sector. I think the private sector care is world class, world leading for certainly the tip of the population who can access and afford private sector care. I think then there's a second layer that is currently paying for out-of-pocket expenses for healthcare, for whom it is just barely affordable to look after their acute care, but they are reliant in general for chronic care to be conducted in the public sector. And then there's a very large sector of the population that is reliant on public health, where there certainly are pinnacles of excellence, such as the breast center. But in general, we get out into the rural areas, which I do fairly often, and we actually get to populations that where the number of people being treated and for whom there's healthcare way exceeds the facilities.
Carol, you are there agreeing with Ian every step of the way.
Because I think the breast clinic at Helen Joseph works because we have a breast health foundation set up in the early 2000s, that we've got this tie-in between government and private and NGO, because you have to have that, because otherwise it can be demoralizing for the nursing sisters who are coming in, for the ladies who are sitting behind the counters. It's sending them on the Avon walk, doing things like look good, feel better for cancer patients. You've got to have that tie-in, because by and large government can only do so much, and with all due respect is failing to get, because the pot is so big, which is why I'm going to throw back at you. To solve this problem, you've got to start at the beginning, and the beginning is education, not health. We have to educate doctors, we have to educate public. And if I look just in terms of what's available in the private sector, something as simple as taking people in private and asking them to do 4 hours once a month, anywhere, will revolutionize an outcome in terms of what we're seeing in a healthcare. We have problems, we have corruption, we have poor suture material, all sorts of issues, but you can get units to work. People have to be positively managed. You're only as good as your entire team.
Deputy Minister, I think we're going to create here an advisory panel that can work with you to create solutions. You've got an enormous portfolio. Education is the key. It must be high on your priority list.
Brilliant. I'm really excited that actually all members of the panel are part and parcel of the solutions already. And we worked together. I think together we also hosted the International Breast Cancer Forum, and so we do work together, and that's the way to go. The first strategic priority on our 10-point plan is to build cohesion and also to ensure leadership, collective leadership. What I want to also present to the panel and the audience is that certainly we've gone a long way as South Africa to integrate almost 15 departments of health in the public sector into a single National Department of Health, yes, with provincial platforms to deliver services. Our economy, the GDP, percentage GDP that we spend on health is 8.5%, and that's amongst the highest globally. And for that amount, we're not getting the adequate output, the benefit, the value. And that is the crux of the matter for the national health insurance system, especially in the light of our constitution that guarantees health for all citizens. Effectively, the public health sector of that share gets about 3.5%, and the rest is with the private sector. And it does not also go directly to healthcare, direct healthcare costs. It goes into administration, into profit margins, and so on and so on. So what we are trying to do is to ensure that there's greater value for money for the health rent, and there's quality assurance, and we also are able to ensure that health is viewed as a public good from an economic term. Because there are many people who are financially secured, and they just have to have one catastrophic health condition, and they go into ICU, or they have a major op, for whatever reason they are thrown into insolvency. So the national health insurance system intends to ensure the constitutional right to healthcare, to ensure quality, and also to ensure that people are protected from financial ruin as a result of just being sick.
Major strides in the healthcare industry in Africa include, for example, the development of the national health insurance. South Africa's medical costs are amongst the highest in the world, and the aim of the NHI is to make healthcare affordable and accessible to all. But this plan has become the center of many heated debates. The panelists at Investec's Captains of Industry event for medical professionals unpack the concerns.
You've mentioned the national health insurance a couple of times. We've got a significant amount of this debate to spend on NHI because the questions that have come from the audience ahead of this discussion, a lot of them have to do with NHI, further clarity. When are we going to see NHI coming into being? Do you have any of that clarity here?
Most definitely, we are quite advanced in finalizing the policy paper. And we had to make sure that we have consulted and followed up all the inputs we got from the green paper. And I can actually with certainty give assurance that it is just a few weeks, maybe a month at most, or 2 months or so. But we are almost done.
Almost done. So we'll see it this year.
Most definitely. And I think many of the stakeholders will be able to see their inputs through that national health insurance system. And it focuses on also preventative care and health promotion, because at the rate at which we are going, there is no health system in the world that can afford the 4 epidemics in one, the quadruple burden of disease, HIV and TB, which we are containing, which is great as South Africans. The second one is maternal and child problems, especially morbidity and mortality. We also containing that. One of our provinces, the Free State, for instance, has recorded more than 40% improvement in maternal survival. And the third one is non-communicable diseases. There are many young people in the prime of their lives as professionals who died 40, heart attacks and all that. And lastly, injuries and trauma. So it is important as South Africans to remember that national health insurance system is about health, it's about wellness. and indeed quality.
We're going to come back to it, Deputy Minister. Thank you very much. Johnny, I'm going to ask you to come in here. NHI, it's imminent. It's going to be here before the end of the year. What impact is it going to have on medical aid schemes as we know it?
So, I think obviously the devil will be in the detail, and we're all waiting very keenly to see what the white paper says. But I think it's almost inevitable in a country and an economy like we have that we will have a system in which the NHI builds out essentially what we today think of as the public healthcare system, the public sector, that has to take care of the vast majority of the population. And it's going to be a work of many years to strengthen and improve outcomes, quality of care, build the promotion and prevention services that the Minister's spoken about. I think while that's happening, and even when that is fully developed, and we've heard from the Minister himself and from others that we're talking about 10, 15 years to get that system up and running to the level that I think we'd all aspire to. I think during that time and even after that time, certainly our view is that this is an economy in which there will be a plurality of a healthcare system. If you look at the richest countries in the world with very well developed health systems, the UK, Australia, Canada, all of Northern and Western Europe, all of those have highly developed national health systems, often health insurance systems, and you have between 10 and 30% of those populations still purchasing private health insurance after their contribution to the NHI. So we see both systems existing, for as far into the future as we can see. I think it's critical that everyone in the private sector, corporations and citizens work towards building the NHI. We can't survive as a society unless it's a success.
Do you think that NHI is going to bridge the gap that Ian referred to earlier between private sector, which is private sector healthcare, which is world-class, and the public sector, which is where we have these gaps?
I think there's one factor that's becoming overwhelming, and from all the panelists so far, we're coming off a low-tech space. In this country, we have a minority that needs to look after the majority's healthcare. And that's something that if we accept that from the beginning and work from the public-private partnerships is the only way that we're going to make things work. We have Dr. Benn, for example, with her initiatives, fantastic work in the Breast Center of Excellence. Secondly, so the Smile Foundation, Dr. Ramokgopa was very helpful and instrumental in us setting up the Smile Foundation. We've cleared backlogs in this country for cleft lip surgery. It's just an example of a really amazing public-private initiative, and the only way is to incentivize people. So I liked your take on getting people to be enthusiastic again.
Let's move on now to more solutions, and one of them that has been tabled by an email ahead of this debate is the use of mHealth, which is mobile technology in the provision of healthcare services. Any thoughts on this, Deputy Minister? Ian, it looks as though it's ringing a bell with you.
I'm very happy because that's one of the delegated matters by the Minister to my office. And I've already established a multi-sectoral forum for to advise on this matter, which includes industry and health and researchers and the medical profession. We have finalized an e-health strategy. At the core of it, it's mHealth. And we are already using some of the solutions. We've got a number of pilots in this regard, including also in monitoring of the compliance for patients who are also already on antiretroviral treatment. So yes, mHealth is one of the options. I'm aware that the Health Professions Council has raised concern in terms of the responsibility of the doctor and the respect of doctor-patient relations. And as we finalize this aspect and the ethical issues, that's the way to go.
In mobile health, mobile technology in health, you've seen it in action?
So you asked a little earlier what we do to brand ourselves. I think that one of the key parts that we've tried to brand within both the research unit and in Right to Care is innovation. And I think the low-hanging fruit in innovation is actually all the technologies. Yeah. I think every single person in this room certainly, and probably in most of the general public, have bank accounts. And unlike Carol, most of us actually do know what our bank balances are. And we go in on the internet to check that. So why is it that we can distribute banking services widely across the entire country with an ATM in every town of this country, yet in healthcare we go, sorry, technology can't work? And I think the leapfrog in efficiency needs to come out of electronic medical record systems, particularly actually in the public sector. We shouldn't be waiting for the private sector to prove this to us, because the need is greatest in the public sector. I think the government, certainly stockouts, have been a major issue. Government is introducing a central procurement strategy with a principle called 7-27-70. 7 health diseases, 27 drugs represent 70% of all medicines distributed. So why don't we get the manufacturer to deliver directly to the hospital? How do we do that? We tied up with a technology system that enables us not to do a pull system, which is the ordering system, but to actually predict in every hospital what drugs they need. And so, in fact, we do a push system. That then goes to the last mile, and most of you will have seen the automated pharmacy just down the road here at Grayston Pharmacy. But in fact, the first of that, we're very proud to say, was actually at Helen Joseph Hospital. And so the antiretroviral therapy treated patient today goes in and is recorded on an electronic medical record system, has the NHLS laboratories directly inputted into his record, doctor scripts, and passes it across electronically to a pharmacy, which in turn passes it electronically to a robotics instrument that does the picking. Waiting times have been cut. The cost of dispensing has dropped from 33 Rand to under 18 Rand per script. The stockouts have been obliterated. Stock losses in terms of expired stock have been obliterated. Those are technology solutions that I think government should be looking at, certainly for the big centers.
I made an enormous faux pas when I sat down and had our briefing, in that, and Johnny, you pointed out, I'm the only one that isn't a doctor on this panel. I spend most of my time interviewing captains of industry, financial experts, GDA graduates, et cetera, and my question was, quite innocently, how do you brand yourself as a specialist, as a doctor, rise to the top in your industry? What about financial security? And I was met with, let me say, hostility, because that's not what this is about. This is about helping people, and I stand corrected. Carol, I'm going to hand over to you at this point.
Yeah, I think, it's all good to talk national health insurance, but we need to encourage youngsters, why follow a field in medicine? Why do you want to do it? And it's not I'm here to help people, because people do want financial security. They need to realize that it's hard work, and I think by and large people choose the medical career because a lot of them see a way in which they can make a difference. And what I want to point out, whereas we're going to walk hand in hand from a government point of view, we have to be so careful. My junior consultant always points out that doctors are like cats. They circle around one another and often don't work so well together. And we need to do that. We need to be a multidisciplinary approach to everything, from the general practitioner to strengthen teams, because if we're going to work in teams, we're going to protect the patients. I intrinsically don't like private medicine because it's not peer-reviewed. So people can do what they like, when they like, how they like, and I think that's wrong. So how do you protect yourself? I always find it very lonely if you're working in private and you don't have someone you can talk to. So if you have a team of doctors who are working together, not a case of I refer to you and you refer back to me. I'm talking a team, people coming from different practices who are going to meet and make sure there's best practice for the patient. It only makes your practice increase and look better, but from a government point of view, we have to be able to offer that in the government setting.
What I feel here is that you are all representative of the following. If you do what you love, you won't work a day in your life. And I think that is embodied on this panel.
Absolutely. I think passion is what must drive you. You won't be happy. You must wake up every day happy to go to work. And if you don't have that passion, you won't be happy to do that. I think what Carol said is so important. Hard work shouldn't feel like a chore. Yeah. Hard work should be part of us. It should be part of our value system. South Africans have come such a long way. And I always think about this. I often think back to my days, and Carol again will bear me out. 3 o'clock in the morning, Chris Hani Baragwanath Hospital, Saturday night. I've done my 5th laparotomy for the night and feeling proud that I managed to take out another colon that was shot to pieces by a gun out there in the township. And all that was the work we had to do to get to where we are now. becoming a plastic surgeon wasn't an easy job. It's a difficult vocation to get into, and it's a difficult one to stay in. And it's hard work. I think it's effort, and it must come from passion.
Thank you so much to Ian, to Carol Ann, Deputy Minister Ridwan, and Johnny. It's been an absolute pleasure. Thank you for joining.